I will be quick. I will just touch a few issues that I think are important for the future of treatment, actually. I will start just a few slides on the state of the art, but actually you know where we are. We start at NCD4. We have 29 approved drugs, which is 5 broad mechanistic classes, and there is also another one coming. I'll show you. 10 recommended first-line regimens around the world, but one standard strategy actually really recommended. High virological activity, very safe. Generally speaking, we went a long way with safety, convenience and access, and also costs. We discussed the future costs, particularly in the low-income countries. The costs are decreasing. So this is where we are with antiretroviral therapy. We aligned all the guidelines on starting very early. We discussed today also test and treat, but with some small changes or issues regarding the WHO guidelines, where of course below 350 CD4 is still strongly recommended, but even the WHO recommends starting on any CD4. We saw, I was a young doctor here at the beginning, and actually we went through a lot of drug development during these last 20 years, and I don't want to go into all the recommendation on what to start with. We discussed this at length. Generally speaking, the integrase, of course, are now our first-line choice. Even in the WHO guidelines, dolutegravir, for example, is an option for starting therapy. So this is the most important and striking results that I saw recently is the life expectancy of our patients. You remember the life expectancy of our patients grew over the years, but now a couple of papers, actually from different countries, confirmed that if you treat well and early, the life expectancy of our patients is even better of that of an uninfected person. And what's the reason for that? I think the reason is because we have good drugs, virus is suppressed, and also they go to the hospital often. So maybe they are cared for different things. And so that's very striking, and actually it's confirmed in other studies. Then, of course, we have the issue of treatment as preventing transmission. And this is really an extraordinary trial proving that if you are HIV positive, you are fully suppressed, you don't transmit to your partner. And that's really striking. And then, of course, this is an old study, but just remember that treatment is also prevention. We knew since many years when we started treating pregnant women. And so that's the old 1994 study proving that antiretroviral therapy, even with monotherapy, was able to reduce transmission. Now we are almost zeroing HIV transmission from pregnant women to children, at least in the rich countries. And this is what happened many years ago. Then another treatment as prevention breakthrough was the discovery that taking pills before having a high-risk behavior may prevent you acquiring the infection. So that's pre-exposure prophylaxis. And actually it's not a new concept. We use it for malaria for years. But actually, you see, those are all the efficacy trials of PrEP, and actually they are all positive. It depends, of course, if you take the pill, because in some cases with very good adherence to the PrEP regimen, the efficacy was like 95%. So really it is a great reduction. And I don't want to go into the details, but actually this is a very important issue. Now, the future. We need to perfect, or we are still perfecting, antiretroviral therapy. There are news regarding safety, tolerability, and convenience. For example, the introduction of TAF, which is licensed, and we know that TAF actually improve renal and bone toxicity with respect to tenofovir, and has similar biological efficacy. So that's a new drug. It's not new because it's already licensed, but that's an advancement. The low dose efavirenz, which has been also incorporated and as an option, even in the WHO guidelines, is the result of the ANCHOR trial. I'm not a fan of low doses, but still it's there. And then we have now the raltegravir QD. It's a lot of milligrams actually, but it works. And so that's on the convenience side. But then we are talking, and Anton and others talk today, I don't want to go into this, about the two drug regimens that are on the horizon. With Mark and Charles today explained why we started with 3 drugs and now we can go to 2 and maybe to 1 is an issue related to the what we call barrier to resistance, which improperly called barrier to resistance, but Charles today explained to us exactly the mechanism why we may think at going with less drugs. So the first studies have been done with the nuke sparing. We wanted to take out the nucleosides because of the toxicity of this class, and there are a lot of positive studies on that. But there are studies also on double combination of PI and integrase, and Anton Pozniak today showed some of the results, the NEAT that we run together in Europe was partially successful. But the most interesting, and I don't want to talk to you about this, Pedro is here, yes, because I put that Friday we have a late breaker on the paddle study, which is the double dolutegravir 3TC study, which really looks interesting. At least the 36 weeks, no, the 24 weeks we saw, correct? We'll see the 48. Okay, so that's right. So stay tuned, and so the future actually will be a lot of single drug combinations. Those are only a few, but drug companies and generic companies are planning to do a lot of single drugs, single pill for the future, and more to come. Now we also have new classes coming. Someone will say, do we need other drugs? Of course, we have 29. In a sense, the history of antibiotics tells us that one day we stopped to do new antibiotics. Now we are terribly chasing other new ones because resistance spread. But maybe if we use well those that we already have, maybe we will not have this spread of antibiotic resistance like the antibiotic resistance. But still, there are new drugs coming. The attachment inhibitors, those are interesting because inhibits the CD4 binding to GP120. So again, is a new class of the attachment entry inhibitors. And there is another one, which is okay, this is the new class. Actually, this looks like a nucleoside, but it's not a nucleoside. It's called now EFDA. The new class should be named NRTTI. It's a very interesting new drug in development, and it looks very potent. And actually, it works well on resistant strains. So that's something that we were missing for a long time: new nucleosides. And then another class is the maturation. Also, in this case, it's a totally new boy at home, and actually, again, it looks working. It looks very well, and again, it works against some resistant strains. So this is for the future. And then, what are we doing regarding PrEP? As I said, PrEP is a breakthrough. We will see why. And there will be now also, this is a study that came out recently, but it will be discussed also at that conference, the use of PrEP on demand. So this is a way to improve convenience to PrEP, which I think will be very important for prevention. And let me say also that we have other drugs. You know that now PrEP is based on tenofovir, mainly on tenofovir TTC, but new drugs are being explored, because why PrEP should work only with that drug is the same that we had with transmission of mother to child. We use AZT because that was the trial. You remember we had to incorporate AZT in all our pregnancies because we had the initial 1994 study that licensed AZT for that. But there is no reason not to explore other possibilities, and they are coming. Now, again, in terms of perfecting PrEP, but I'll come to this. We are talking about, and I will show you about injectables. Today, someone presented some of the injectables. Now we also the era of implantable is coming, which are a little different. Injectables are injected and difficult to get out. Implantable is different, as you know, as many women know, implantable devices that release the drug may be taken out easily. So the implantable devices are coming. And again, someone spoke about the injectable. Injectable is really a breakthrough. Actually, the injectable formulations are actually the original drugs formulated in nanotechnology. And we have rilpivirine and cabotegravir, which is actually dolutegravir. And also we have very nice data that I'm not anticipating, because you will have on Thursday the late breaker of 48 weeks of the LATI. Anton spoke about the LATI study, where we see that after an induction period, an oral induction phase, then the injectable combination keeps the viral load low for 2-3 months, let's see. But very, very, very interesting in terms of, that's I think is a real breakthrough. They are not available yet, but they may. So what's the future of art? I think it's difficult that we may increase activity. We are at 90 something if the drug is taken. Viral load reduction. We may increase the safety and tolerability. Convenience also will come, particularly, for example, the injectable, the numerous single pills coming. Affordable, of course, prices will go down, and we know about dolutegravir combinations in low-income countries that may reach $100 per year per patient, which is unbelievable low. And so affordability, accessibility, again, will increase. It should increase because we have this goal of 20 million by 20. you know that these goals seemed unrealistic, like the 15 by 15, but then you reached this goal. So I think it's good to put goals. Life expectancy, at least will be the same. Let's say we have some data about the better, but let's say that even the same is good. So the future, I think, we went from, you know, the discovery of HIV through mono, 2, 3, now 2 again, then now injectables. I don't know what the future will hold. But let me touch, just very shortly, on an issue which is on my heart, which is treatment as prevention. I said already that since the trial was published, we know that this effect in stopping transmission is there for antiretroviral therapy. And let's say that the story of antiretroviral therapy in low-income countries actually started here. And I'm very proud to have here Mark. He was the president before me. We worked together to bring the conference in Durban in 2000, so you understand how old we are. And it has been a fantastic history. To bring it here is also very moving for us to be here again, let me say. But then after that, after the year 2000, after the Global Fund, etc., an amazing target has been achieved. As I said, now we have 15 million people surviving, and not cured, of course, surviving, alive because of the antiretrovirals. And so with this success, the UN put forward this goal. I like the goals because they push us to, you know, to do things. It means by 2030, make end of AIDS as a public health, not end of AIDS in terms that there is no HIV in the world, but just to say that HIV is no more a public health problem. Is it reachable? So that's the question that, I mean, some of us may have. I mean, I like the goal. Let's say that it may be reachable if we behave well. And for example, let's say the UNAIDS put forward this slogan or this target, 90-90-90. It's a strategy which is based on the concept of treatment as prevention, saying, okay, if we treat a lot of patients, the majority of the HIV-infected patients, then the spread of the virus will be stopped, and then the HIV epidemic will be curbed. So that's, I think, a very good slogan, particularly because it fosters access. It fosters testing, access to care, and treatment. So it's a great idea. Say, okay, we need to put 90% of patients of HIV positive, we need to test 90%, and then 90% of those should be put on care, and then 90% should be fully suppressed. And with this, we can curb the epidemic. I think it may work, and actually, if it doesn't work, that's the problem. The problem is that we may have a resurgence of the HIV epidemic. So, and this is a message that even CDB gave us yesterday. Hey, be careful, it's not over. Actually, the data that we have are not totally reassuring, the recent data, because the number of infections is increasing. So if we do a reality check with the 90-90-90, we see that the reality is not, we are not yet there. There is a long way to go. Although some countries like Australia, I don't know if we have Australian people here, said they reached this goal. In Australia, they said HIV is no longer a public health threat because they have a few patients, a good system, good education, access to care, good doctors, good drugs, and that's it. So some countries, even in Europe, like Denmark and other countries, are almost there. Even Italy. Someone called me the other day and said, hey, we are, because I never speak about Italy, but actually we are like France or UK, yeah, or Holland. Denmark is even better. No? Holland is better. Okay. I don't know if Jens is here. Anyway. So, no, just to do a reality check. The reality check is that if you look at the cascades around the world, we are not there. Those are the testing. I mean, look at these countries on the right is a catastrophe. I was in Moscow recently, really there. In the Eastern Europe is really but there are some very good African countries actually in the first 90, the testing. This is the patients on art. And look again at China, Russia. It's really frightening. We are not there. We are not there. And look at the suppressed. Very few are suppressed in some countries. In Russia, 20%. When I was to Moscow and I was speaking with the governor, I mean Medvedev assistant, I said, you know, the country that barely does worse than you, USA. So you are on the same, game. Actually, USA is a problem because, not everywhere, but overall, because their access to care is poor, because their health system, and here you see the importance of the health system, because they don't have a universal health coverage, then it's very difficult from the testing to get into the system. Then when you are there, then you are suppressed. But there is a gap in between, and that's and actually this is what UNAIDS diffused yesterday. You see the number of new infections is still there. So I think there is a lot to do. I would like you to go tomorrow. There is a very important 1990 session tomorrow, and treatment as prevention, because we need to focus on this. And this is what the UNAIDS report said. I mean, unfortunately, while significant progress is being made in stopping new HIV infection among children, I mean, fortunately, the decline in new HIV infections among adults has stalled. So that's a reality. We still have a long way to go. And those are the pillars that they put forward to say, okay, how can we do this? And one is the key populations. To understand that the epidemic is not the same everywhere. So there are different epidemics, and each epidemic should be targeted. And the issue is, again, the key population. And for example, young women is a key population, at least in South Africa, and in many other, because of the gender disparity, all the issues of the gender issues. But also look at the probability of acquiring HIV. IV drug users have 36% more probability of acquiring HIV than a non-IV drug user. So really those are and actually the key populations now are the 40% of the total percentage of HIV infected persons in the world. And what's the problem there with respect to treatment as prevention? Is that treatment do not reach them. So the problem that they are not reached by treatment, or it's difficult to reach them, means that they will continue to transmit. And they may vanish the positive effect of all those that are treated. So we need to focus on key populations. Those are the transmitters, the future transmitters. And also the last issue that I wanted to touch is retention, because of course we have 15 million on treatment, but this doesn't mean they will stay on treatment for 50 years. 50 million on treatment means that 15 million people took the first pill, or the second, or the third, or the 120th. But then they need to stay there for 50 years. So that's a little different. And you see, actually, the retention is 50% of 5 years in Africa. So it means that these 15, of course, we will put others on treatment every year, but some of these 15 will stop during these subsequent years, and they will have a resurgence of viral load, and they will start infecting others. So the retention is a dramatic issue, and here is a possible solution that also UNAIDS and others and the IS are pursuing. We need to simplify the way patients are getting antiretrovirals. We can do it, and this is, for example, in our patients I have here Rafaela that works on this project in Ethiopia, and the patients say, but can you tell me why should I take this pill forever? I say, because you may become sick. And they say, when I don't know exactly. So let's wait, because I'm okay now, correct? I'm asymptomatic. Yeah, but inflammation, and it's very complicated to explain that the virus is still there, but you don't see it, but then it's making damage. It's the same problem that we have with statins. I always forget to take my statin because I didn't have a myocardial infarction yet. But actually, some of the patients also say to us, I stopped. Why did you stop taking pills? Because I'm okay now. I thought I was cured. Say, no, you are not cured. So I need to continue, yes. And you know what they tell me? They say, okay, I will continue. And you remember, we had a meeting with the community, and they said, okay, I will take the pill. I trust you, but you need to tell me that one day I will be cured. So if you tell me this, if you promise that you are working on that, then I follow you. If you tell me that it's forever, then I prefer to live without the pills, particularly these pills that make me sick. Now, fortunately, we have better drugs, because that's the problem also. Maybe with the better drugs, we'll do a better job. Anyway, to make a long story short, this is the overarching barrier, because we need to double our investments. We are spending 15 billion, and we need 30. Of course, 30 billion looks an enormous amount, but it's almost what UK lost in 10 minutes after they lost it. No, they lost 350 billion in a day. Then, of course, they will recover it because the Brits are smart. But that was what. So in 5 minutes, that's a global fund. So anyway. So we need a lot of money, but let's hope that we will work. So what CDB said yesterday is the only way to secure the next big breakthrough is a cure and a vaccine, in addition to treatment. So what I'm saying is that we need to don't think one way. We need to. Drugs are fantastic. They saved life, they stopped transmissions, but I'm scared they will not be able to curb the epidemic alone. And this is actually what I said in Lancet a few months ago. I said, hey, look, we need to tell the people that we are not at the end. This was Winston Churchill talking about Brits. During the war, Winston Churchill, after the first success they had against Germany, the people was, in the street saying, hey, hey, it's the end. Say, no, no, it's not the end. It's not even the beginning of the end. Maybe it's the end of the beginning. So there will be a long way. And this is what we need to tell to the politicians that think it's over. They think it's over. Say, hey, well, we invited also my president, the IS, sent a letter through me. He didn't even reply. Say, well, what's AIDS? Wasn't it disappearing? Say, no, it's not disappearing. So anyway, we need to make clear that we are still a long way to go, and the way forward is following the science. So that's my little final part. This is Fauci. I met him today. It looks like in 1975. It looks the same. I met him actually before the AIDS epidemic, and is exactly the same, with the same brain, smart, nice, and he wrote this, follow the science. So what's the science? The science is prevention, combination prevention. So we need to use whatever we have. Treatment as in the first option, but we have a lot of other things. PrEP, we need really to foster the use of combination, because prevention, and not just one. And then I close, because cure is indeed the future of therapeutics. Is the future of therapeutics. Why do we need a cure? It's very obvious, because I think that it's clear that current treatment has some limitations and has to be taken every day, maybe every 2 months, but still for life. And there is a problem of sustainability, of costs. Will we be able to sustain, to put on treatment 35 million people forever? And those that come, because you know that every year we have 2 million more. So this is Françoise, that I borrowed this slide for her. Lifelong art for all is unlikely to be sustainable. And there is patient hopes and willingness. This is what the patients tell me. The first thing, say, okay, the pill is here. Okay, thank you, I understand. But one day, one day, so okay, I'll do it. But I need to give this hope. This is why we need also to invest on the cure. And of course, there are different types of cures. What we think we could do is a remission. Complete eradication will be difficult. But remission, so let's say staying alive without the need to take drugs, maybe. Personally, I'm a fan of the cure, of the real cure. The other thing is a half and half, okay? It's like losing the final of the World Cup, the final, okay? At the penalties. So I am a fan of the cure, and I don't think the remission is it happened. You know, these patients, the French patients, but they are the usual 22. They are always these, how they call the Visconti patients, the elite controllers. They are 33. Every year we have 2 more, but it's so I'm not a fan of the remission. I think we need to go to eradicate, and there are a number of barriers. I don't go into this. We don't know even where the reservoirs are. We don't know which cells are the real ones to target. And for example, one possibility is the genetics. Now they are thinking at engineering the cells to take out the CCR5, but also to eradicate the integrated DNA. Today there is a very nice conference on cure, today and tomorrow actually. Maybe we can be able one day to cut out the DNA, the HIV DNA, integrated DNA from the infected cell. I doubt. But anyway, it's interesting. What I'm focusing now is on therapeutic vaccination, immune-based therapies, and latency reversing agents. Actually, there is a word there, discovery of novel biomarkers. This is an issue because, as Charles knows very well, because we have a project together on that, we still have an obstacle to measure the real reservoir, because integrated DNA is a word, and then the functional one is another thing. So we are still a little bit, we still need to go back to basics, correct, Charles? But again, look at what we are trying to do with this immune. In a sense, we are trying to be helped by a great ally, which is the immune system. And maybe through this incredible group that won a European project, which is called EVA, where we are partners, we have a strategy to cure. Let's say the goal is to work towards a cure, not to cure. It may be more difficult. The strategy is based on trying to reverse HIV latency. There's been papers around that looks at some drugs, and others will come that will, reverse the latency, so the virus will awake from the latent phase in the cells. So it will replicate again, and then it will be cut by the drugs. And the other part of the story is immune-based therapy. So in a sense, the story is called shock and kill. Shock because we awake the virus and then we kill the latently infected cells. But we need to have, let's say, armed defenders, which are the T cells. And we are trying now to work on the immune checkpoint breakthrough that is used on cancer. You know, this breakthrough in cancer therapeutics where someone discovered, actually the discovery was many years ago, but now that the immune system become exhausted after certain time of responding to too many antigens. So this exhaustion of the immune system is the cause why even in cancer the immune system doesn't work, doesn't clear and today with monoclonal antibodies, which actually are also used, and it's the way forward for the vaccine research. You will see a lot of vaccine advancements during this conference. There are drugs that are the immune checkpoints inhibitors that, in a sense, reopen the switch of the T cells and make them functional again. And so in our strategy, what we do, we give a vaccine to the patient. We make the virus be awakened again, and then there was a very nice article in the New England recently that was Release the Hounds. That was the title of an article on cancer therapeutics. Because actually with these immune checkpoint inhibitors, some cancer patients were cured, even from metastatic melanoma. So actually, we know now that the immune system can do a lot. And this is therapeutics, actually. So this is actually, some of the results with the immune checkpoints in cancer. You see the curves are significantly different. For years, we didn't have any of this change. Yeah. And now in my lab, for example, because the immune checkpoint inhibitors are a lot, the immune checkpoints molecules are a lot. It's not just PD-1, which is the one that is used. There are a lot. What we are working now is on bispecific. We are producing bispecific immune checkpoints inhibitors to make them more potent and more specific. So that's just what we are doing in our lab. And you see the initial data, if we use bispecific monoclonal antibodies, their potency is far better than the commercial one. And so I'll finish here to give you a hint of real, maybe a distant future, but we need to have distant goals to hope. And I would like to thank, of course, Charles, with whom we are working on that, Anton Pozniak, that always is my mentor and gives me a lot of slides, and Trip Gulick also because of the slides, Françoise Barré-Sinoussi, Raffaella, who is here because of the work in Africa and his research there, and my monoclonal antibody group. We are just a few, but we are, you see, 5 young people there. Thank you.